For decades, standard medical practice has relied on a simple assumption: a low mass of LDL cholesterol in a patient's blood equates to a low risk of cardiovascular disease. Yet in clinics everywhere, patients suffering from prediabetes, obesity, or metabolic syndrome frequently develop severe atherosclerosis despite having optimal LDL cholesterol scores. Doctors call this clinical anomaly residual risk. The flaw lies in the mechanics of the standard lipid panel. The test only measures the total weight of the cholesterol cargo floating in the bloodstream. It completely ignores the absolute number of vehicles carrying that cargo. Relying strictly on LDL cholesterol mass in a metabolically unhealthy patient creates an illusion of safety that overlooks active, progressive vascular disease. Apolipoprotein B100, or ApoB, provides the biological solution to this measurement problem. Human biology follows a rigid stoichiometric rule. Every single atherogenic particle carries exactly one ApoB protein on its surface. Measuring the total serum concentration of ApoB provides an exact count of circulating dangerous particles, independent of the cholesterol mass inside them. This particle count reflects the cumulative risk in insulin-resistant patients, identifying the specific atherogenic burden that mass-based measurements often miss. The biological breakdown begins in fat tissue. In an insulin-resistant state, unrestrained free fatty acids aggressively flood the portal circulation and overwhelm the liver. The liver overcompensates for this heavy influx by manufacturing and secreting massive triglyceride-rich VLDL particles into the bloodstream. Through an active remodeling process, enzymes strip these large particles of their core, shrinking them down into high quantities of small, dense LDL particles. The result is a sharp contrast to healthy biology. The patient's actual LDL cholesterol mass shrinks or remains static, while the absolute number of ApoB-carrying particles skyrockets. Insulin resistance alters the physical structure of cholesterol, maximizing the concentration of these small, dense particles in the blood. Simultaneously, a parallel biological track alters the structural integrity of the arterial wall. Chronic hyperinsulinemia and systemic inflammation force vascular smooth muscle cells to overproduce specific proteoglycans. The body then enzymatically alters these proteoglycans, producing longer, highly sulfated glycosaminoglycan chains. The physical consequence is severe. The subendothelial space transforms from a smooth surface into a highly negatively charged, physically sticky trap. In the insulin-resistant state, the increase in circulating particles occurs in parallel with a structural shift in the vessel wall that favors their retention. The two tracks collide here. Small ApoB particles expose positively charged domains, electrostatically locking on to negatively charged arterial chains. This chart shows physical evidence. Human interstitial fluid studies demonstrate diabetic patients experience a 58% drop in ApoB particles returning to serum compared to a baseline. The immediate consequence of this entrapment is devastating. The trapped particles rapidly oxidize, trigger macrophage recruitment, and fuel the aggressive growth of unstable plaques. This synergistic entrapment model explains why advanced, vulnerable atherosclerosis accumulates silently and rapidly in prediabetic patients, long before they are ever formally diagnosed. Accurate cardiovascular risk assessment must now account for the synergy of a high particle burden colliding with retentive vascular walls. Major lipid societies and cardiovascular guidelines have adapted, integrating targeted ApoB measurements to uncover the residual risk that standard tests miss. Measuring ApoB, or alternatively non-HDL cholesterol, is a diagnostic necessity for patients presenting with obesity, high triglycerides, or metabolic syndrome. Standard LDL cholesterol panels are inadequate for evaluating the modern, metabolically dysfunctional patient, making ApoB testing a required clinical tool. Combating this dual pathway disease requires aggressive combination lipid-lowering therapies, specifically targeted at clearing ApoB particles from the blood. While statins are the foundational treatment, they often leave behind dangerous small, dense particles. This requires the addition of advanced agents like PCSK9 inhibitors or bempedoic acid to maximize clearance. The second half of the strategy attacks the metabolic substrate. Incretin-based therapies are deployed to promote weight loss and resolve the underlying insulin resistance driving the disease at its source. Effective management addresses both sides of the equation, clearing atherogenic particles from the blood while repairing the metabolic environment that drives their accumulation.